Hola, buenas tardes a todos. Good day to all, wherever you are. Good morning, Toronto. David, it's a great pleasure for me to present Dr. David Cherney as the keynote speaker in this symposium of the new development in diabetic kidney disease. Dr. Cherney is a leading nephrologist for the University of Toronto. He is an expert in renal physiology, and he's one of the world's leading nephrologists in this area. He's a professor of medicine at the University of Toronto and the Hospital Research Institute, and director of the renal physiology laboratory in the University Health Network. We are really very lucky to have him with us in this Congress because he will fill us in on the latest development in regarding of diabetic kidney disease. I also would like to thank Novo Nordisk for the sponsorship of this symposium. And we're going to have 30 minutes of talk with Dr. Cherney, and thereafter we will be followed by a 30-minute question for the audience. Please prepare your question to send via the chat. And thank you very much, David, for being with us.
My pleasure.
Wherever you want.
Hello, my name is David Cherney. I'm a nephrologist at the University of Toronto, and it's a pleasure to talk to you today about new treatments for diabetic kidney disease. I also want to thank the organizers for inviting me to speak with you today. So these are my disclosures in this area. And by way of objectives, we're going to talk about several different areas, given that this is a field that's really expanding very rapidly, which is exciting for patients and for physicians. We're going to talk about the SGLT2 inhibitors and their mechanisms for kidney protection briefly, and some of the key clinical trial data. We'll also talk about the GLP-1 receptor agonists, and focus on semaglutide, including some of the rationale for kidney protection, the trial data, and of course the mineralocorticoid receptor antagonists and diabetic kidney disease, given that we now have data from the Fidelio trial with finerenone. So with regard to factors that we've targeted to reduce the risk of kidney disease over the last 20 years, until the recent trials that I'll talk about over the course of this talk, we really had very little in the way of advancement for treating diabetic kidney disease. We focused on glycemic control, attainment of blood pressure targets, as well as the use of ACE inhibitors or ARBs in people with albuminuria, and of course, reducing cardiovascular risk factors such as hyperlipidemia. But beyond this, we had very little to offer our patients, especially those at the highest risk of progression. And so in trials such as IDNT and RENAL, which are shown on your left-hand side, there were significant improvements in the risk factors and the composite endpoints included in those trials. But unfortunately, patients still had a 30 to 40% risk of going on to develop primary endpoints, despite the use of angiotensin receptor blockers. And similar observations were made in people with non-diabetic kidney disease, shown on your right-hand side, in that ACE inhibition decreased the risk of composite endpoints in patients enrolled in that trial, but patients still had significant residual risk despite the use of those standards of care. Which brings us first to the SGLT2 inhibitors. And we're going to go through these therapies first because this is where the new data developed first in terms of the cardiovascular outcome trials, which initially showed the renal benefits for these therapies. And then we'll talk about the GLP-1 receptor agonists and mineralocorticoid receptor antagonists afterward. The SGLT2 inhibitors were originally used because of their glucose lowering effects by blocking the reabsorption of glucose and sodium. That led to a glucosuric and natriuretic effect, which lowered A1C and weight. And the natriuresis is also, of course, important with respect to reducing blood pressure and possibly improving some other risk factors, including the risk for development of heart failure. From a renal perspective, there are a whole bunch of mechanisms that may be relevant for kidney protection, and this likely involves mechanisms that are important for people with and without diabetes. And just very briefly, these therapies reduce cardiovascular risk, which may in turn improve and maintain renal perfusion and protect the kidneys. They reduce blood pressure and have benefits around vascular parameters, which may benefit the kidney. They improve metabolic measures, including A1C and weight, which is of potential particular importance for microvascular endpoints. They also reduce pro-inflammatory and pro-fibrotic pathways and improve oxygenation in the kidney, all of which may be beneficial for reducing kidney risk over time. The reduction in albuminuria, as well as the reduction in the need for loop diuretics, which dry our patients out, may also be important for preserving kidney function. And one of the best studied mechanisms involves reducing glomerular hypertension, which is important for people with and without diabetes, and important early and also later in the disease condition. So these are all mechanisms that may be important for preventing kidney disease progression. But regardless of the mechanism, we know from previous trials, including EMPIRIC Outcome, Canvas, Declare, and Credence, that were summarized in this meta-analysis by Brendan Newen, that there are significant reductions in the risk of end-stage kidney disease, substantial loss of GFR, or renal death in patients across a range of GFR. And you can see that there are benefits with GFR of over 90, 60 to 90, 45 to 60, and less than 45 in this meta-analysis across these different GFR thresholds, highlighting that there is a broad potential for the use of these therapies to reduce renal risk. So there are a variety of trials that have now looked at the effects and benefits of the SGLT2 inhibitors in people with different etiologies of kidney disease. The Credence trial involved people with and without, involved people with diabetes, and those patients had to have a GFR of between 30 and 90 and macroalbuminuria. Whereas in contrast, DAPA-CKD, which is a trial that I'll tell you about in a little bit more detail, included people with and without diabetes as the etiology of their kidney disease, with GFRs that were a little lower, 25 to 75, and macroalbuminuria. That's, of course, also very important because it built on Credence by including people with and without diabetes in DAPA-CKD. And then finally, in the future, we'll have data from EMPA-Kidney, which also is recruiting people with and without diabetes, has the lowest GFR threshold down to 20. And in the 20 to 45 range, patients do not have to have albuminuria. They can be normo, micro, or macro albuminuric, whereas those with GFRs of over 45 do have to have albuminuria. So these trials all build on one another and will much more completely elucidate how these therapies can be used effectively and also safely. So the Credence trial was the first trial, involved, again, people with type 2 diabetes only, and reduced the risk of the primary endpoint, including end-stage kidney disease, doubling of creatinine, renal, or CV death by 30%. And there were also important cardiovascular benefits observed in the Credence trial, involving reductions in MACE, CV death or hospitalization for heart failure, and the more specific renal composite, which was end-stage renal disease, doubling of creatinine and renal death reduced by 34%. So really important renal and cardiovascular benefits that were observed in this trial. But how about in people with non-diabetic kidney disease? And this is important because many of the mechanisms that I mentioned earlier may apply to people with non-diabetic kidney disease who aren't hyperglycemic, such as the intrarenal hemodynamic effects, as an example. And so to better describe and understand the mechanisms in people with non-diabetic kidney disease, we recently completed this trial called Diamond, which looked at the effect of dapagliflozin in people with non-diabetic proteinuric kidney disease. And we randomized patients to dapagliflozin or placebo, followed by a crossover, and then a washout rather, and then a crossover to whatever patients weren't on in the first phase of the trial. Our primary endpoint was proteinuria. We also measured iohexol GFR, and a variety of other parameters. And in this trial, while we did not see an acute effect on proteinuria, which was the primary endpoint, we did see an acute effect on measured GFR with a dip in GFR of around 6.6 mils per minute, which was also acutely reversible. So there was a hemodynamic effect of this therapy acutely, but no impact on proteinuria over the short term. So it appears that the effect of SGLT2 inhibition still has the physiological changes and induces those changes in people regardless of ambient hyperglycemia. But this was only a mechanistic study. What's really important to understand is outcomes. And so to look at outcomes in people with and without diabetes, as I mentioned earlier, the DAPA-CKD trial enrolled people with GFRs between 25 and 75 with UACR above 200 milligrams per gram on a stable maximal tolerated dose of an ACE or ARB, and people could be enrolled with and without type 2 diabetes. The primary outcome was a composite of sustained 50% or more decline in GFR, end-stage kidney disease, renal, or CV death. And I will also tell you about some of the composite secondary outcomes too. So at baseline, the mean age of the cohort was 62, a third were female. The cohort, in terms of the cohort ethnicity distribution, 52% were white, 5% Black or African American, 35% Asian, and 8% other. 2/3 had type 2 diabetes, mean blood pressure at baseline 137, eGFR 43, and UACR 965, and 97% were on a background of an ACE or ARB. So very similar albuminuria level compared to credence, but the GFR, the mean GFR at baseline was about 10 mils lower than in credence. So this is the primary outcome, which was significantly reduced by 39%, highly statistically significant, leading to a number needed to treat of only 19. These are some of the components of the primary composite outcome. So a 47% reduction in 50% decline in GFR. There was a 36% reduction in end-stage kidney disease, including reductions in GFR less than 15 and a reduction in chronic dialysis. No impact on CV death, which is important and a point I'll come back to in a moment. For the purpose of this discussion around the effects in people with and without diabetes, this is also a critical slide which shows that the effect of dapagliflozin in terms of the primary outcome did not differ based on the presence or absence of type 2 diabetes. You can see the p-value for interaction was 0.24. With effects that did not cross the line of unity in people with or without diabetes, showing similar effects and benefits in those two subgroups included in DAPA-CKD. Also no heterogeneity around albuminuria or GFR above or below 45, suggesting that the benefits are seen quite widely in the population that was included in DAPA-CKD. For secondary outcomes, there was also a reduction in the specific renal composite, so 50% decline in GFR, end-stage kidney disease, or renal death. There was a reduction in the composite of hospitalization for heart failure or CV death, and a reduction in all-cause mortality. So there was a reduction in all-cause mortality, but no reduction in CV mortality, suggesting that there may be other etiologies of mortality that are benefited with dapagliflozin, and it'll certainly be interesting to get more information about the specific causes of death that were reduced in this trial in future work. So we've talked about these trials already. As a reminder, credence only in people with diabetes, DAPA-CKD in people with and without diabetes, but with albuminuria, and DAPA-CKD is the ongoing trial that has the lowest GFR range and includes people with normal, micro, or macro albuminuria in this lower 20 to 45 GFR range. And that's important because those patients have not been included in previous trials, including credence or DAPA-CKD or IDNT or renal. So this is a unique opportunity to see if a therapy is effective in people with lower levels of albuminuria. So next, we're going to go on to the mineralocorticoid receptor antagonists. And so we're going to shift gears from a therapy, the SGLT2 inhibitors, which were originally used in the setting of diabetes and hyperglycemia, and are now being used more and more as sort of pleiotropic cardiorenal risk reduction agents that appear to modify the natural history of the disease, which is extremely important. In contrast, the mineralocorticoid receptor antagonists have been used as therapies that reduce blood pressure and that also reduce cardiovascular risk in people with heart failure and reduced ejection fraction. But there were in the past some smaller studies that suggested that there may also be benefits for blocking the mineralocorticoid receptor. There may be benefits in the kidney as well by reducing factors such as pro-inflammatory and pro-fibrotic mechanisms, thereby reducing renal injury and reducing clinical evidence of diabetic kidney disease progression. So blocking inflammation, blocking oxidative stress, and blocking fibrosis. Now, this came into even clearer focus over time with the observation that MRAs, when added to a RAS inhibitor such as an ACE or ARB, have been shown to have effects on reducing proteinuria in people with kidney disease. But importantly, it was hard to use these therapies in people with kidney disease in the past because of the risk of hyperkalemia, as well as the risk of sexual side effects with older mineralocorticoid receptor antagonists. And that's where finerenone comes into play, in the sense that this is a novel non-steroidal mineralocorticoid receptor antagonist that has greater receptor selectivity than spironolactone and better affinity versus eplerenone. And in previous work with finerenone, in a study that called the ARTS study involving people with heart failure and moderate kidney disease, there was a significant reduction in albuminuria that was reported. So a follow-up study called ARTS-DN, or ARTS diabetic nephropathy, was subsequently designed to compare the efficacy and safety of different once-daily oral doses of finerenone versus placebo in people with type 2 diabetes and albuminuria receiving an ACE or ARB. So in the ARTS-DN study, the primary endpoint was around albuminuria, and you can see that there was this nice dose-dependent reduction in albuminuria with finerenone, especially at the higher doses of 15 and 20 milligrams. Importantly, there was also a relatively low risk of hyperkalemia leading to discontinuation of only about 1 to 3%, which is probably lower, although there was no other mineralocorticoid receptor antagonist arm in this trial. This is likely lower than historical levels of hyperkalemia leading to discontinuation with older MRAs that have been looked at in the past. So a favorable efficacy profile and a relatively reassuring safety profile. But this was, of course, the rationale for doing the Fidelio DKD trial, which was a much larger randomized double-blind event-driven placebo-controlled phase 3 trial, which randomized over 5,700 patients to finerenone or placebo to assess important cardiorenal endpoints. So the specific primary kidney endpoint was the first occurrence of kidney failure or a sustained 40% decline in GFR or renal death. The key secondary CV endpoint was 4-point MACE, so CV death, non-fatal MI, non-fatal stroke, hospitalization for heart failure. And then there are a variety of secondary outcomes, and I'll tell you about some of those today as well. So in terms of the cohort that was involved in the Fidelio trial, patients had a mean age at baseline of around 65, most male, so about 70% male, A1C 7.7%, BMI around 31, blood pressure around 138/76. And in terms of kidney-specific characteristics, the mean GFR at baseline was around 44, so very similar to DAPA-CKD. And the UACR was 852, so a similar range as Credence and DAPA-CKD, but a little bit lower. Serum potassium at baseline was around 4.4, and that's important because patients couldn't be hyperkalemic at baseline to be included in this trial. So in terms of medical history, at baseline, about 7.7% of patients had HFpEF or mild HFrEF. But of note, patients with symptomatic HFrEF were excluded from the trial. So this was not a heart failure trial, clearly. But a significant proportion of patients did have a history of cardiovascular disease at baseline, as shown in the fourth row in this table. So this is the primary outcome composite and also components of the composite. And the major observation was that there was an 18% reduction in the primary composite kidney outcome, which was highly statistically significant. And this was driven mainly by a reduction in the risk of a sustained 40% or more decline in GFR. But as you can see, the other components of the composite were also on the favorable side of unity, although they did cross unity. So it was these components together that drove this overall benefit with finerenone. For the CV outcomes, there was also a 14% reduction in the risk of the key secondary CV outcome with effects that were driven by various components of this composite. That 14% reduction in the composite was statistically significant. So a benefit around the primary and a benefit around the secondary CV outcomes in this trial. For some of the additional endpoints, there was also a significant 30% reduction in urine albumin to creatinine ratio with finerenone, an effect that's similar to what we see with SGLT2 inhibitors, similar to what we see with RAS inhibitors, and even with GLP-1 receptor agonists as well. So this is a clinically meaningful reduction in albuminuria. And this is GFR over time. And what's perhaps most interesting about this curve is that not only is there a better preservation of GFR overall with finerenone versus placebo, which is what you'd expect, there was also this acute effect of finerenone initially, suggesting that there is a modest hemodynamic effect of finerenone, which may be and reflect a reduction in glomerular hypertension, which may contribute to some of the benefits that are seen with these therapies. So there may be several mechanisms of related to the benefits, including reductions in inflammation and fibrosis, perhaps a reduction in glomerular hypertension, and that certainly merits further study down the road. So that's efficacy. This is the safety, some of the safety data from the Fidelio trial. So overall, finerenone was well tolerated, not associated with an increased risk of AEs or serious adverse events. So for example, serious AEs, 31.9% with finerenone, 34% with placebo, which is certainly encouraging. There was also no imbalance around kidney-related adverse events, and there was no imbalance around sexual-related side effects such as breast hyperplasia or gynecomastia, which is also very good for patients because this is one of the things that prevented the use of older MRAs that did predispose to some of these reproductive and breast disorders. Importantly, for hyperkalemia, although investigator-reported hyperkalemia was more common with finerenone, the clinical impact was modest in the sense that if we look at and just hone in on these two bars in terms of hyperkalemia leading to discontinuation, was 2.3% with finerenone and 0.9% with placebo. So certainly there is more hyperkalemia, but the rate of hyperkalemia leading to permanent discontinuation was quite was relatively unusual, and there were no cases leading to death. So important, and emphasizes that hyperkalemia certainly needs to be thought about, followed, and managed, but that it appears to be relatively unusual in terms of a side effect leading to discontinuation. So let's move on to the GLP-1 receptor agonists now. And this is also absolutely a very important area that's being actively investigated. And similar to the mineralocorticoid receptor antagonists, one of the major benefits with the GLP-1 receptor agonists, one of the major benefits may be around reducing inflammation and fibrosis. And so the GLP-1 RAs are inducing natriuresis. They may have hemodynamic effects, although in humans that appears not to be the case in most of the published studies to date. They also inhibit the renin-angiotensin system. They reduce oxidative stress and inflammation. And of course, for indirect effects, they also improve a lot of overall renal risk factors such as hyperglycemia, blood pressure, and weight, all of which may contribute to renal benefits over time. What we know with the GLP-1 receptor agonists is that they certainly reduce albuminuria, and in the LEADER and SUSTAIN-6 trials, which were cardiovascular safety studies, there was the consistent observation of a reduction in the composite nephropathy endpoint, but importantly, this was driven by a reduction in the risk of persistent new onset macroalbuminuria. So in contrast with the SGLT2 inhibitors, where there was a reduction in the risk of declining kidney function and a reduction in the risk of renal replacement therapy in some of the trials, a lot of the benefit in these cardiovascular trials was driven by albuminuria primarily in terms of the overall cohort. And we'll get into that in more detail in a moment. Importantly, for mechanisms and for changes in kidney function over time, we know from the LEADER trial that there doesn't appear to be a hemodynamic effect or an acute dip that we see with the SGLT2 inhibitors or that we see with the mineralocorticoid receptor antagonists. As you can see, there is this quite steady level of GFR over time with no evidence of this acute dip, and that's been replicated in other studies where they've measured GFR at even earlier time points. So not a hemodynamically driven benefit based on what we know so far, likely driven in terms of the benefits by suppressing oxidative stress, inflammation, and other injury mechanisms. But what we do know, if we look in a little bit more detail from these trials, and this is data from LEADER and SUSTAIN-6, what we do know when we pool the data from these trials, recognizing that these are not renal cohorts, these are cardiovascular risk cohorts, that we really do see this very nice and consistent signal for reducing loss of kidney function over time, either a 30 or a 40 or a 50 or a 57%, which is a very high bar to be able to achieve. There is a significant reduction in the risk of reaching these thresholds for GFR decline in people with GFRs between 30 and 60 and micro or macro albuminuria. So in patients who were enriched for having renal disease at baseline just by circumstance that they happened to have kidney disease at baseline, there appears to be this very substantial reduction in the risk of reaching these thresholds for clinically important kidney function decline over time, which certainly is an area that merits further investigation. We also know with dulaglutide from the REWIND study that there was a significant reduction in the risk of new macroalbuminuria, but in a sensitivity analysis, just like in the previous slide that I showed with liraglutide and semaglutide, there was also a significant reduction in the risk of a 40% or more decline in GFR and a significant reduction in the risk of a 50% or more decline in GFR, showing that there is a really compelling rationale for looking at these therapies in people with kidney disease at baseline, especially who are at the highest risk of going on to develop kidney complications over time. And that's the rationale for the FLOW trial. The FLOW trial, which is ongoing, involves more than 3,000 patients with type 2 diabetes on standard of care therapies with lower GFR and with albuminuria at baseline, who are being randomized to semaglutide or placebo and then followed over time for the requisite number of endpoints. The primary endpoint includes the time to first occurrence of either an onset of persistent 50% or more decline in GFR, GFR less than 15, or renal replacement therapy, both of which, in terms of the GFR less than 15 or renal replacement therapy, reflect end-stage kidney disease, or renal death, or cardiovascular death. So very compelling cardiorenal endpoint that we've seen in previous trials. And once we have the results of the FLOW trial, we'll definitively know whether the GLP-1 RAs reduce a renal risk in a dedicated renal cohort. So in summary, what I'd like to end with are a few thoughts. First, that the SGLT2 inhibitors induce renal protection through pleiotropic effects, and that includes people with and without diabetes. And we know that now from not only DAPA-CKD that we talked about today, but also from EMPEROR-reduced and DAPA-HF, which also included people with heart failure and reduced ejection fraction with and without diabetes. We talked about the Fidelio trial, which is exciting as it's a new kidney protective therapy class that can be added to current therapies that are used in the clinic today. And finally, we talked about the GLP-1RAs, which have the potential for inducing additional renal protective effects on top of other therapies, including SGLT2 inhibitors, including novel MRAs, and have their unique mechanisms of action, all of which may be both specific to those therapies, but may also be complementary to one another. And finally, we have to work on the implementation of these trial results, which is an urgent priority since some of these therapies are already available, such as the SGLT2 inhibitors. We have to make sure that our guidelines reach our patients so that we treat them appropriately and safely. So I'll end there and thank some of the research teams who have supported some of the research studies that I've mentioned in this talk, and I'll look forward to questions and comments. Thank you.
Thank you very much, Dr. Cherney, for this comprehensive talk about all the new developments in diabetic kidney disease. We are living in an incredible moment of our patients, with a lot of new trials, a lot of new events, a lot of new demonstration of the new treatments and evidence. Oh, okay, let's move to the chat. We have a lot of questions for the chat. First of all, Dr. Bober, any information on better potassium control with SGLT2 inhibitors or GLP-1 agonists in these studies?
In terms of blood pressure control?
No, potassium.
Oh, gotcha. Potassium. Thanks for the question. So, and also thanks again to the organizers and to you for inviting me to be included in this session. I think this was very useful for reviewing some of the really exciting areas. So I'm very fortunate to be here with you. In terms of the potassium issue, there was a lot of discussion earlier on with the SGLT2 inhibitors about whether they could, in fact, impact on potassium either way, either an increase or a decrease, because with the GFR dip that we see with these therapies, there was a concern that with a reduction in GFR initially, there may be a rise in K. And then alternatively, with the natriuresis that's seen and the increase in luminal flow, there may be a reduction in potassium. So the interesting thing is that, that overall, there seems to be a small reduction in potassium by somewhere around 15% in potassium levels. Generally is not detectable clinically. You can only see it in the context of a large trial. So overall, the SGLT2 inhibitors are, if anything, neutral on potassium, possibly a slight reduction in potassium. And that will certainly be interesting with respect to potentially neutralizing the rise in potassium that's seen with some newer therapies like finerenone, for example, or mineralocorticoid receptor antagonists. So that needs to be looked at in more detail, but that's a potential synergy that can be taken advantage of with the SGLT2 inhibitors plus other therapies that tend to raise potassium. Okay, thank you very much.
It's a complicated question, but you have explained it perfectly. Dr. Soler, do you foresee the renal endpoint will be in a future unified as it is in MACEs? Because we cardiologists are MACEs. It's very easy. It's simply the easy. But what's happening with the nephrologists? We are a very way of measuring our endpoints.
Yes, agree. Thanks for the question, Dr. Soler. So that's a very important question that's been the topic of a great deal of discussion in nephrology for years now. And you know, to be very frank about it, it's disappointing that we don't have a uniform definitions yet. I think we're moving in that direction, though, and I think that the SGLT2 inhibitor trials have really helped push us towards adopting a 40% decline in GFR rather than going for 50 or 57% decline in GFR. It's certainly a clinically relevant threshold of 40% decline. It's reasonable to achieve within the relatively short time frame of a clinical trial where we only have 2 or 3, maximum 4 years to capture endpoints. And a lot of this was very nicely summarized in a commentary and review by Dr. Levin from Vancouver in the journal Kidney International about a month ago. So that reviews many of these issues that have really plagued us in nephrology And that's a worthwhile read to talk about and think about some of these ongoing issues. But I think, yes, we are moving towards a uniform definition of 40% decline in GFR, renal replacement therapy or renal death as being the renal specific endpoint in clinical trials.
Okay, thank you very much. Dr. Soler, there are several questions about the SOM issue. How do you explain that reduction in 30% of GFR was not significant benefit with dulaglutide, but it was significant with the reduction 40 or 50% with rewind?
Yeah, so I think the 30% decline in GFR is really a bit of a tricky measure, and I would strongly downplay and not favor 30% decline in GFR. And that's because we can see 30% changes in GFR quite frequently with other illnesses, patients who are admitted to hospital with an infection or with dehydration, or who start an ACE inhibitor or a diuretic, or sometimes rarely even an SGLT2 inhibitor. So the 30% decline in GFR is subject to a lot of noise and a lot of other events that do not represent significant kidney function decline from the underlying disease. It can basically represent mild acute kidney injury from other illnesses. So the key things there are, one, is it sustained? So does it stay below 30%? You'd think that acute kidney injury would be that 25, 30% and then go back up to where it was. And then number two, does it represent an acute event, such as acute kidney injury from an illness, or does it represent true decline? And so I think the 40% decline in GFR that we saw, and rewind was even showed a benefit around 50% decline in GFR that was sustained. That's really important because that doesn't represent kidney injury or acute kidney injury. That represents a sustained decline in kidney function from the underlying disease. So I think the key issues are ambient noise and then real signal from GFR decline from diabetic kidney disease. So that's a great question. Thanks for bringing that up.
Okay, you mean that 40% is an appropriate cutoff in order to avoid noise, to avoid other functional deterioration of renal function, and probably maybe the future for considering or MACE or male renal adverse events. Okay.
Absolutely. Yeah, totally agree.
Okay, and concerning this, there's another question that, concerning the hemodynamic effects of GLP-1 receptor and agonist. Could you please clarify if there is any hemodynamic effect after the introduction of GLP-1 receptor and agonist? Because you have shown a tiny increase in GFR with leader study in those patients with GFR below 60, because the GFR is increasing. And on the other hand, award 7 with dulaglutide versus insulin has shown the same increase in GFR. How do you explain, how do you clarify this hemodynamic effect of GLP-1?
Yeah, great. Also a great question, and very important clinically, because we think about the dip in GFR with the SGLT2 inhibitors. So do other therapies cause that too? So the answer is that generally they don't. So GLP-1 receptor agonists tend to be extremely neutral around GFR change. And that's shown perhaps most clearly with data from LEADER and SUSTAIN-6, where compared to a placebo, as opposed to an active control with the dulaglutide CKD trial that you mentioned, that there is a neutral effect on GFR initially. Certainly by between 3 and 6 months, there really is no trend in kidney function change over time. And there are a whole bunch of mechanistic studies that have been done over the last 15 or so years that have looked at both measured and estimated GFR changes in response to either GLP-1 infusion or GLP-1 receptor agonists. And overall, there really is no consistent signal for a GFR change up or down. So I think the message is that GLP-1 receptor agonists are neutral around GFR, and that's in contrast with the SGLT2 inhibitors, which cause this typical dip in GFR.
Okay, thank you very much. Dr. Roberto Alcázar asked about hyperkalemia in those patients, but not exactly with finerenone, but we can include this. I would like to know your opinion about real-life hyperkalemia risk in diabetic kidney disease patient treated with RAS inhibition, and how to minimize the risk, because the Fidelio show are incredible, very, very low degree of hyperkalemia.
Yes.
apart from Fidelio, Roberto Alcázar is worried about the real life studies and the real life, because we have a lot of hyperkalemia. How do you, what is just to minimize the risk?
Yeah, so that's a very common scenario that many of us face in the diabetes and kidney disease field, and that's a really real concern that we have to deal with on a day-to-day basis. And so the risk is real, and patients with diabetes, those with low kidney function, especially with age over 70 or so, there is a significant increase in the risk of hyperkalemia, especially because of the so-called hyporeninemic hypoaldosteronism. And that's made worse by ACE inhibitors, ARBs, and also mineralocorticoid receptor antagonists broadly, and I'll get back to that in a second. The strategies to mitigate hyperkalemia essentially come down to diet and then non-dietary factors. And the dietary factors we can counsel our patients about. And then with regard to pharmacotherapies, diuretics can be important in order to increase the amount of K that we get out of the system. Making sure, in addition to that occasionally we use potassium binders, and there are new potassium binders that many of us are now using in order to either get our patients on a RAS inhibitor or to keep our patients on a RAS inhibitor when their potassium levels are high, generally above 5.4, 5.3, 5.5, that kind of range. So the potassium binders really come into play when we've given our patients dietary advice, when we've used diuretics, and then we have nothing left in the toolbox except for trying to keep them on their kidney protective therapies and then start a binder. So that's the situation right now, even before we have finerenone. I agree with you that I think the risk with finerenone was very, very low overall in terms of rates of hyperkalemia leading to discontinuation. It was approximately 2.3% with finerenone and 0.9% with placebo. So really quite unusual. And in those patients, that's a situation certainly where, given how effective finerenone was in the Fidelio trial, where we might now consider using a potassium binder to keep our patients on a RAS inhibitor plus an SGLT2 inhibitor plus finerenone when we're using it in the future to further reduce kidney disease progression. So we're going to be layering therapies in our patients, just like we do in the setting of heart failure, to try to reduce their risk, but we'll have to also mitigate the side effects, and that includes mitigating potassium risk.
Concerning this, in Fidelio, the curves opened a little bit late. And does this imply the predominance of anti-inflammatory, antifibrotic mechanism, as you have suggested?
Yeah. So absolutely, in Fidelio, the lines separated nice and slowly, and the in terms of the 40% decline in GFR, which was used as the key measure in the primary outcome for a significant kidney function loss. And so the slow separation of the curves was very much, in terms of the primary composite outcome, was very much driven by a reduction in the risk of a 40% decline in GFR, which we would expect to happen very, very slowly, because it suggests that something is preserving kidney function and thereby preventing loss and preventing GFR slope. So to my mind, that does very much emphasize or highlight the role for suppressing inflammation and fibrosis with finerenone. Although I would also emphasize that in the Fidelio trial, there was also a small dip in GFR initially of about 2 mils, which suggests that there may be a very modest hemodynamic effect also, which may also be protective, because we know that reducing glomerular hypertension is beneficial in diabetes and in people with kidney disease and albuminuria. So there certainly seems to be a role for suppressing inflammation, and then there may be a role for reducing hemodynamic injury as well.
Okay. Do you think that the addition of finerenone to SGLT2 inhibitors could have a synergistic effect on albuminuria? Because Fidelio, in patient optimally treated with RAS inhibition, decreased more than 30% albuminuria. Do you think what will happen in the future with SGLT2 inhibitors with finerenone about this possible synergistic effect of albuminuria?
Yeah, so what we can certainly hope for is that that by adding these two therapies together, that we get an added effect on reducing not only albuminuria, but that we get an added effect on reducing CKD progression. So I suspect there will be an added effect on reducing albuminuria. And I suspect that there will also be an effect that's beneficial around preventing renal function loss. But I think that and there may be a safety benefit as well by preventing the rise in K by using the combination of an SGLT2 with MRA. But I think we really need the trials to tell us that. And ideally, we'll have data in the future, not only around albuminuria and safety, but also around preventing more rapid GFR loss. And remembering that people in Credence, for example, they still lost about 2 mils per minute per year on canagliflozin, and they still had rapid kidney function loss. And patients in Fidelio also still have GFR loss. So we still have residual risk that we have to attenuate. So hopefully combining these therapies will be beneficial in an additive fashion. We need the data though.
Okay. Dr. Secundino Cigaran asked about this topic with what's your opinion about the use of finerenone in indication of heart failure? We all know that the concentration of finerenone are higher in kidney than in heart. But what do you think, or do you have experience or some studies using finerenone in heart failure?
Yeah, so there are some smaller studies in the setting of heart failure, and in the ART study, the ART's original study, there were benefits in the kidney and even in patients with heart failure, and there are certainly some signals that the lines of benefit around heart failure signals are potentially on the side of benefit with finerenone. But the Fidelio trial specifically was not a heart failure trial. In fact, patients were excluded if they had symptomatic HFrEF. So I think to answer that question, we're really going to need the data from Figaro, which is the sister study of Fidelio, and we'll then be able to combine the primary and secondary outcomes in these trials and have something like 12,000 patients in the two trials, and we'll be able to answer this question in a reasonable way. There's certainly a lot of physiology that supports a heart failure protective effect, but we just need the data.
Okay, I apologize because I have hundreds of questions on those.
No. This is great. This is great.
You have mentioned that finerenone produced a modest hemodynamic effect, and by reducing the hyperfiltration you have mentioned previously. What's the mechanism by which finerenone induced this hemodynamic effect? We
just don't know. There's a whole bunch of literature around the effect of blocking the mineralocorticoid receptor in vitro and in vivo in animals. There are mechanisms, and I'll tell you just a few of them because there are many, around interactions with nitric oxide. There are potential interactions around IP3 and other calcium-related signaling pathways and vascular smooth muscle cells. But it's just not known with finerenone yet, if this is, to my knowledge, if this is an efferent or an afferent effect that reduces the GFR acutely, or if it's relaxation of the glomerular capillary tuft. We just don't know. But I think what we do know is that it's not a blood pressure effect, because the blood pressure lowering in Fidelio was very modest. It was a tiny effect, statistically significant, but it certainly wouldn't reduce GFR. So it's some sort of intraglomerular pressure effect, and what the precise mechanism is absolutely needs to be elucidated.
Mm-hmm. Okay. Leader and SUSTAIN studies only demonstrated benefit in reducing proteinuria or new onset or persistent microalbuminuria, but both studies doesn't demonstrate the benefit in renal progression. And you have presented in the S.E.N and the European Congress, not the Congress, the combination of pooled studies that demonstrate altogether benefit. Recent post-hoc studies to combine data from LEADER and SUSTAIN demonstrated the benefit in renal progression. Do you think it was because it wasn't a study with a renal endpoint appropriate number of patients? Will FLOW resolve or solve or answer this question?
Yeah, that's a great point, and I'm glad you brought it up because of the FLOW trial that's ongoing. So as you alluded to in post hoc analyses of LEADER and SUSTAIN-6, when patients with GFRs of between 30 and 60 and micro or macroalbuminuria were pooled, there was just a beautiful effect in those patients on preventing either a 30 or a 40 or a 50 or a 57% decline in GFR over the course of the trials of LEADER and SUSTAIN. So those are the patients with renal disease who happen to be enrolled in these cardiovascular outcome trials, which were the rationale for LEADER and SUSTAIN-6. So that suggests that there is a benefit in people with established kidney disease at baseline. And that's exactly why the FLOW trial is being done, to look at the effect of semaglutide in patients with kidney disease at baseline with albuminuria, to examine the effect on a characteristic or typical cardiorenal endpoint, including significant GFR loss, end-stage kidney disease, renal or CV death. And we'll have that answer from FLOW in the future, which is which is this ongoing trial that we're still doing. So yes, I think it'll answer the question one way or the other, and I think there's a very supportive rationale for it, given these results from AWARD, but also from REWIND and also from the LEADER SUSTAIN series of trials.
Okay. Do you think, concerning the side effect of GLP-1 are underused in general, especially in our country? Do you think chronic kidney disease patients may experience more side effect than other after GLP-1 administration? Pharmacokinetic study doesn't demonstrate this. Pharmacokinetic study has demonstrated the area under curve are similar in patients with hemodialysis or normal renal function. Do you think our patient experience more side effects?
Yeah, great question. So there was a nice analysis by, I think Johannes Mann was the first author, who published an analysis of LEADER looking at the safety and tolerability in people with kidney disease, and the answer is exactly what you're saying, that there was no clinically important difference in terms of the side effect profile in patients with kidney disease versus those without kidney disease. Patients with kidney disease experience side effects, of course, but it's not different compared to those with higher levels of GFR. So I think that these therapies are absolutely underutilized in people with kidney disease. They're very safe. And they have benefits around glycemic control that are preserved as kidney function deteriorates. And certainly there is the rationale that I mentioned for at least including these patients in trials, and perhaps even using these as kidney protective therapies in the future. So not only do endocrinologists have to get comfortable with them, but cardiologists need to get comfortable with them too, because of their cardiovascular and anti-atherosclerotic effects. And then nephrologists will have to get used to using them too, because of their use around glycemic control, but also potentially for kidney protection in the future. So they're safe and efficacious, similarly in people with and without kidney disease. That's the bottom line message here.
Okay, you know that obesity is one handicap for including waiting list for kidney transplantation in most cases, but there's not allowed on label for using GLP-1. Have you experienced in patient dialysis using semaglutide or GLP-1 in order to lose weight?
Yeah, so there isn't a lot of published data out there. I'm not a transplant nephrologist, so I don't treat those patients. But there are a handful of smaller studies reporting that essentially the expected effects around metabolism are similar in transplant patients. The side effect profile doesn't appear to be very different either. But these are small studies, and in my opinion, I think that this is an area that's also ripe for future studies, both mechanistic studies and potentially also transplant studies. And remembering that in the setting of renal transplantation, there is absolutely equipoise around even the use of RAS inhibitors. And so we have to understand GLP-1 receptor agonists and SGLT2 inhibitors in those patients.
We're going to move to SGLT2 inhibitors in the last minutes.
Sure.
Could the glucosuria damage the epithelium, or could glucosuria damage the epithelium in some cases?
Yeah, so that's a question that's come up in the past, especially earlier on when we were starting to use these therapies. And I'll answer that in two ways. The first answer is around a familial condition called familial glucosuria. And these are patients who have essentially an inborn mutation of SGLT2, and they have glucosuria their entire lives. And there are even families in Spain who have this condition, and there is no evidence of any long-term adverse renal effect from having familial glucosuria genetically. My second answer is pharmacologically. we know that based on the results of DAPA-CKD, of credence, and all the CVOTs in more than 50,000 patients, that the risk of composite renal endpoints is reduced by between 30 and 60%. And in DAPA-CKD, mortality was reduced significantly. So I think we can definitively say that glucosuria by itself is not bad. And in fact, inducing glucosuria along with all of the other mechanisms with the SGLT2 inhibitors clearly and definitively has benefit for our patients, preventing dialysis by probably somewhere between 10 and 15 years in patients with established albuminuric kidney disease.
Okay, there is a couple of questions about this study. First question, do you think there is a class effect on SGLT2 inhibitors, and what do you think the cause of the lack of significance of renal outcomes in Vertis trial is the using the first 57% instead of 40% reduction GFR? Yes,
thanks for the question. So I agree with you. We were a little surprised initially when we presented the key secondary renal outcome using the 57% decline in GFR, which did not reach statistical significance. We think this is likely on the basis of how that was defined. So it was just a doubling of creatinine. So it wasn't a sustained definition, which many of the other trials used, and it was a very, very high bar to have to reach for a cardiovascular risk cohort. So that's why we subsequently reported renal endpoints using a 40% decline in GFR instead, which is much more accepted, much more uniform, and also probably much more reasonable for a cardiovascular cohort that has a much lower kidney risk. And indeed, when we did that, there was about a 35% reduction, which was statistically significant, around losing 40% decline in GFR or the composite using that definition. So I think there probably is a consistent effect. I don't like the word class because it means everything's the same. It's clearly not the same. But I think there are very consistent effects around the benefits of these therapies, especially for heart failure and especially for kidney disease progression.
Yeah, Dr. Martinez Castelao has an interesting question. Which is the reason to explain that in non-diabetic patients do not suffer hypoglycemic episodes on the SGLT2 inhibitors? The question of threshold.
Yeah, absolutely. So the question is, why is there no hypoglycemia with SGLT2 inhibitors? And there are a few reasons for that. The first is that even in people with diabetes, the SGLT2 inhibitors tend not to cause hypoglycemia unless patients are on a background of insulin or an SU, a sulfonylurea. Insulin and SUs, they do cause hypoglycemia. An SGLT2 inhibitor would lower average blood sugar, and then the insulin would then induce the hypoglycemia. So it's not actually the SGLT2 inhibitor that does that, even in people with diabetes. The reason that SGLT2 inhibitors don't cause hypoglycemia overall in people with and without diabetes is that as blood sugar declines, you can imagine there's less filtration of glucose. So the drug essentially turns itself off because as you get into the normal and then the low range, there is little glucosuria, so there's little effect of the drug. And the other observation is that hypoglycemia induces a renal vasoconstriction. And so as hypoglycemia evolves, there is some evidence that there may be a reduction in GFR and hence an even greater reduction in filtration of glucose, which also turns the drug off. So there are at least several mechanisms for that.
Okay. Last question, because we have no time. Because for example, I know that in Canada, when we are talking about some analysis of different countries, there is a high uptake of administration of new drug, SGLT2 inhibitors and GLP-1, more than in Europe and more than in Spain. Which strategies do you suggest to implement this new evidence-based treatment among the community in nephrologists in our community? Because we are still at about 4% of GLP-1 and normal 15% of them, because they are all the treatment that have demonstrated that evidence-based for reducing progression of renal disease. Which strategy do you suggest and within it?
So I think it's a great question. It's a very complicated matter, of course, but it involves a mixture of being able for the society to be able to pay for the drugs, especially for those over the age of 65, to be covered by either insurance or healthcare plans or Medicare or whatever system is in place locally. And also involves, non-financial related issues around physicians getting comfortable with the use of these therapies. And going back to what we were saying about the GLP-1 receptor agonists, If you're a cardiologist or a nephrologist or an endocrinologist or a family doctor or a general internist, we all have to be used to using these therapies. They are the new ACE inhibitor. And so we can't wait for our colleagues to prescribe them. We have to recognize the indications, if it's an endocrine indication or a renal indication or a cardiac indication, and we have to just start them. We can't wait for other people to do it, or we can't ask other people to do it and then wait, which often doesn't happen. So there can't be that I don't love the term, but clinical inertia or slowness in uptake of therapies. We all have to be responsible for it and start these therapies when there's an indication to do so. I think those are the key things.
Okay, unfortunately, time is over, and thank you very much. My apologies for bombing you about a lot of questions.
My pleasure.
Thank you, Dr. Czerny. It has been a pleasure to have you with us today in this Congress. We have learned a lot with you. I think we will all agree that this is a very exciting time to be a nephrologist. Thank you for your contribution to our Congress. And I also would like to thank Novo Nordisk to the sponsorship of this symposium and to all of you who are accompanying us with this afternoon. Thank you very much. I hope to see you soon for the next time. Bye.
Hopefully next time it'll be in person next time, hopefully.
Thank you.
David. Take care.
Bye.
Bye-bye. Take care.
Bye.
Ciao.